I'm Dr. Nirav Goyal. I'm head of liver transplant and HBV surgery at Indraprastha Apollo Hospital, New Delhi. I'll be talking on hepatitis, which is a scourge which is there present in our society. And this hepatitis may occur from several reasons. And I will take you through the reasons for hepatitis, how to manage it, how to deal with it, and what are the cures and curative treatments available. Pregnancy is a unique immunological period with immunologic tolerance to paternally derived fetal antigens, resulting in altered immune response at the maternal fetal interface, that is, at the placenta, as well as at the systemic level. Alanine aminotransferase levels tend to be lower in the second and third trimester compared to the first trimester. But hepatitis B flares during pregnancy, they are infrequent. It is also reported that for women on antiviral therapy pre-pregnancy who stop treatment when pregnancy is diagnosed, viral rebound with ALT flare appears to occur more frequently, followed by spontaneous recovery in a vast majority of pregnant patients. And co-infection with chronic hepatitis B infection is frequently seen in patients with human immunodeficiency virus due to the shared routes of transmission. And both infections are typically acquired in adolescence or in adulthood. Now, regions with HBV endemicity, such as Asia, have a higher rates of co-infection, estimated between 20 and 30% of all HIV positive patients. When we are dealing with hepatitis B and HIV co-infection, hepatitis B is typically acquired perinatally or in early childhood, with HBV infection often preceding HIV infection by decades. And HIV patients are at higher risk of developing chronic hepatitis B viral infection after acute infection. And co-infection with HIV is associated with accelerated fibrosis, progression, and increased risk of cirrhosis, and decompensation and liver-related death. So both, like with HDV along with HBV, HIV along with HBV, they are in a more fulminated, they are in a more severe, the course of disease is more severe. And it is important to screen for hepatocellular cancer with ultrasound and alpha fetoproteins at 6-month intervals in any patient who meets the HCC screening criteria. The CD4 count of less than 200 is a primary predictor of liver-related death, and lower CD4 count is also associated with an increased risk of developing chronic infection, increased likelihood of HBV reactivation and anti-HBs antibody loss, and increased rates of cirrhosis and HCC. And the effect of chronic HBV on the natural history of HIV appears to be minimal in terms of viral and immunological response to the antiretroviral therapy. Co-infected patients have a similar time to viral suppression and rise in CD4 counts as individually HIV infected patients. And the experts recommend testing patients at risk for hepatitis B virus who are undergoing immunosuppressive therapies. In countries with an intermediate or high prevalence of HBV, screening of all patients may be considered, and testing should include hepatitis B surface antigen, hepatitis B core antibody, and anti-HB surface antibodies. This is for screening for HBV in the setting of immunosuppression, and those without markers for HBV exposure can be offered vaccination. In immunosuppressed individuals, HBV reactivation in the context of immunosuppression is characterized by an initially marked increase in HBV DNA levels, followed by an enhanced immune response with ALT elevation, and in some cases, severe liver injury leading to decompensation and even death. The risk of reactivation varies with the serological status of the patient and the potency of the immunosuppressive drugs, with the highest risk group being those who receive B cell depleting therapies. So HBV reactivation is generally less common in HBs AG negative, anti-hepatitis B core positive patients than with surface antigen positive patients. And HBV is a common indication for liver transplantation in Southeast Asia. In the era of transplantation, HBV was regarded by many programs as a contraindication to liver transplantation due to high rates of graft loss due to recurrent HBV disease. But nowadays, With the newer nucleotides available, it has become routine to do hepatitis B viral positive patients. And in fact, immunoglobulins are almost given up. It's not really required in the process of transplantation when we are talking with dealing with hepatitis B. And these patients, they remain on antiviral therapy for hepatitis B, and depending on whether they were core antibody positive or they were HBs surface antigen positive, the duration of this antiviral therapy may vary. But minimum 1 year post transplant, if they were surface antigen positive, then it continues almost lifelong. Reflecting the effects of immunosuppression on host immune response and HBV DNA replication, HBV was a rapidly progressive disease post-transplant, with the recurrent cirrhosis documented in substantial proportion within first 5 years post-transplant. But this scenario is now changing. Thank you.